This is Michael from Blue Sky Bio. I'd like to welcome everybody who's joining us this evening. We're going to get started in just a minute. We'll let people finish joining and logging in and registering for the webinar. Okay, let's get started. This is Michael from Blue Sky Bio. I'd like to welcome everybody who's joining us tonight. Please make sure to enter your details and contact information into the webinar attendance form so that we could send you the CE credits. Tonight we're going to be hearing part 2 of a 4-part webinar series presented by ROE Dental Lab on the topics of treatment planning and implant planning. Tonight we're going to be hearing a presentation on the topic of proper treatment planning for crown and bridge cases. ROE is a leading dental lab in general and specifically in the field of guided surgery. The presenter, Joe Ambrose, is the head of the guided surgical department at ROE Dental Lab. Joe has more than 3 decades of technical expertise and oversees the success of all technical services, in addition to seeing that all implant and attachment cases are successfully restored. Joe?
Thank you, Michael. I'd like to welcome everybody to session 2 of the 4-session series that I have planned for Blue Sky and everybody that is here tonight. In the first session, just as a little bit of a review, we went over some basic principles of data processing, of what can help you be very efficient at getting data to us, scanning your patients with the proper appliances, or whether or not you need an appliance, so that once we get to the point of planning a case, everything works well. We can plan a case successfully, and also the information was to help you get your scans done correctly the first time and sent to us for the data interpretation. Tonight, I'm going to go into some planning of crown and bridge cases, how grafting planning can be worked into your crown and bridge cases for proper emergence, and also an important factor in the ultimate restoration that you may design is how to recognize emergence profiles in software. And emergence profiles can be planned, and quite often to do it properly, grafting is part of the process. I have some pictures here on screen that demonstrate what some of the ideal parameters are for emergence profile. And if you look at the top right picture, it's a central, or it's an anterior tooth, and the emergence profile, as you see, emerges out of the gums in a gentle curvature as a natural tooth would. And that can only happen if the implant is in such a position that we don't have over-contoured facials, under-contoured linguals, or vice versa. So this design that you see here for anteriors is the most successful and maybe long-term successful design that you can have for a tooth, because it pretty much replaces nature in its form. If you look to the left, you'll see a picture with a missing number 8, but it also shows parameters in dealing with running room. In other words, the distance from the top of the platform to the free gingival margin, and typically the ideal is 3 to 4 millimeters. If we have less than that, it's very difficult to develop an emergence profile that is easily maintained and treats the gum tissue kindly, and it's also very difficult to create a tooth form with less than 3 to 4 millimeters of a sulcus to start the emergence profile out of the gums. Also, you'll see a Tannow guideline of 4 millimeters from the bone to the contact point, so that papillas can be formed, or Tarnow, I'm sorry, not Tannow, Dennis Tarnow, 4 millimeters from the top of the bone to the contact. That can be planned to some degree, and when we can do that, it's going to be very beneficial for papillas. Now, some cases that we work on do not have the possibility of papillas as they're presented to us. However, if enough bone exists, we have the potential to create a situation where we can develop some kind of a papilla by countersinking implants if we have enough room, and working with the restoration in that manner. You'll see in this slide, the top middle, about food deflection, and these contours that you see on this crown are very ideal, and that is what nature gives us to help deflect food as we eat. And this tooth form, for the most part, can't be designed in a lot of the restorations of implants, are too far to the lingual, too far to the facial, where we can't put in good hygienic designs in our crowns. The bottom picture gives us an ideal picture of a posterior tooth and emergence profile. As you'll notice, all of these implants have pretty much ideal bone to be placed in, and really in all the thousands of cases that I've planned, more often than not, we don't have ideal situations to deal with, and compromises are made, and grafting has to be done to achieve some of these placements that allow us to create this kind of a contour of the tooth emerging from the gums. The picture in the bottom middle just gives us guidelines that I think we all know about at this point. The parameters of the implant between the natural tooth, the parameter of inter-implant distance, implant to implant, of 3 millimeters, and the ideal amount of thickness we need between the facial of the implant and the gingiva itself to create a sulcus that allows us to contour crowns in a natural fashion. The picture on the bottom left just shows the difference between the crown design. This crown is going to be a lot more difficult to maintain. It has an overhang that you see here, and that overhang was made to allow this crown to be built out to be in line with the adjacent facials of the tooth and carried down to the gingival, but it also is very bulky here. And at this point of the crown right here, there's a little bit of a concavity. And I have a couple of cases that I'll show you that would have that if we were to design the case with the available bone. But our real goal is the picture below it here, where we have a nice gentle emergence coming out of the gums that allows the patient to hygienically take care of this and aesthetically have a more pleasing case. So the first thing I'll do, I'm not going to get into complicated cases tonight. This is going to be pretty basic fundamental information that can be applied to complicated cases. So we'll start out with screw retained versus cement retained and emergence profile. So here we have a case that is designed for a screw retained crown. And there's a lot of dynamics that go on in planning these that change the position of the implant in the bone, change the emergence profile of a crown in the bone, and changes the thickness of bone on the facial and lingual to a point where it depends upon the practitioner. Are you comfortable with the thicknesses of bone you're working with in a cement retained versus a screw retained restoration? If you notice, this will be a screw retained restoration, and what we want to have happen is to have a 0-degree abutment angle, as you see with this yellow post, and we want it to emerge through the cingulum of the tooth, which it does. And to do that, in quite a few of our designs, we have to angulate the implant in such a fashion that at the coronal aspect of the implant, we quite often end up with pretty heavy bone. And here, this is 3 millimeters as I've measured it. Down at the apex, we start to get into thinner bone, 1.5 millimeters of bone, and quite often thinner than that. So, when you have a crown like this that has this much anterior contour to it from the implant, you can see the emergence profile that we're left with. Now, that doesn't mean it's wrong, but it means that you may have some tissue contouring to do, or some tissue modeling to do with the provisional crown, as opposed to not having to do it if we had a different kind of an emergence angle. But if you design the case for screw retain, and that's what you want to use, quite often this is the result. So your laboratory has to know how to handle these cases. You may have difficulty in placing them in the gums and have to do a curettage to allow the crown to seat, or a releasing incision to allow a crown to reseat. And our recommendation at this point is, when you know you have this problem, to have a custom healing abutment made that pretty much forms the sulcus before the crown is made, so that when we take our final impression, the sulcus is there, and we simply have to make the abutment and fill the sulcus with porcelain as it was shaped with the provisional or custom healing abutment. That can be an entire subject almost for a subsequent lecture. As opposed to, and you'll see here also that on the lingual in this design, we have very thin bone. Quite often practitioners will tell me that they don't worry so much about the thin bone on the lingual. They want to have more buccal bone available for the implant in the crown. So we go now, as a comparison, to cement retained crowns. What we see here is less bone, less facial bone at the coronal, but at the same time we have thicker bone at the apex, because we've changed the angulation of the implant. But the important thing to see is that now our emergence profiles, as you see with these red arrows, are much more gentle and much more natural as far as a crown shape. You also notice that the bone on the lingual is thicker, and in general, the entire implant is placed in the center of the bone in the arch, as you see in the sagittal cut. So any of these designs work. Some require more work to get seated and more preparation than others. So this crown is probably going to be a lot more easy to seat than a screw retained crown might be, depending upon the patient that you have. So here is the comparison. You can see very clearly the difference in the implant positions. So, and there is a controversy right now about cement retained crowns versus screw retained crowns, and the fact that implants are being lost because of the cement junction being too far subgingival. We have the advantage now of planning cases digitally in computer programs, planning the implant placement in computer programs, making our custom abutments on computer programs that put our margins exactly where we want them, so that the margins aren't buried 4 millimeters under the tissue surface. I think, in my opinion, that some of the failures that have occurred because of cement could be practitioner related, but more often I think that these are older cases that may have had to use stock abutments, pre-made abutments where margins are very far subgingival, and you really can't control where they go. And if they're a cement retained crown, obviously the margin is going to be so far under the gums it's going to be hard to clean. But I do think with the advent of CAD/CAM and the ability to put margins where we need them, and the understanding of design concerning margins, that we can control a lot of that and carefully do cement retained restorations successfully. So I have a case here that I'm going to open up and show. Let's see, I think I will. Okay. Let's do it this way. I'm going to go through the process that I went through to make these particular slides and show you the process of planning. And I'll also show you some tools in the software that you can use to help yourself determine these particular angles. And one of the things that helped me a lot with this was the virtual teeth that are in the program. There are two kinds. One kind of virtual tooth is, or I'll show you these right now, the icon right here that has the tooth with a red plus sign brings up the tooth menu, and you'll see tooth with roots, as you see here, and you'll see crowns only. I use both of them to help me determine emergence profiles, and I'll go through a little demonstration on that too. So the first thing I'll do here is I'm going to eliminate the implant and start over. So if you want to see, let's turn this tooth on. Here's a tooth list here. I'll turn that off, turn that on. We'll go to this site. Okay. So let's put an implant in place. Let's just pick a, these are all, this is the library of implants that Blue Sky has in their software, and they're all compatible with implant systems. For instance, we have Astra, Zimmer, Nobel Active, Zimmer tapered screw vent, Straumann tissue stage, Astratech, as I mentioned, and Nobel Replace. So let's just choose an implant that allows us to put a 3mm size in, 3.5, let's say. We'll go to Nobel Active, 3.5 by 11. We'll choose that one first, and we'll place it. So we want to try to follow the angle that the bone gives us, and this is a central, so I can see right now I have a little more room here to put a wider implant in place, so I'm going to replace that with a larger one and go to the 4.3. This looks like a 13 would work better, and we now have a 4.3 by 13mm implant in a central incisor position. So I'll enlarge that so we can see better. Well, this is the crown that's in place now, and obviously this is going to be an immediate placement. So this is going to take some grafting simply to fill up the cavity, the socket that the implant's in after we screw it in, and there's some of the threads exposed. So to determine this emergence profile, it's easy to see, but it's pretty graphic if you go up into the tools on the toolbar up here and go into tools and click add marker, and I will go from here, that's the original, that's the pregingival margin area of the tooth, and I'll do that, and I'll make an emergence profile. And what this means to me is that when we design this crown, this is all subcrestal, subgingival. This is the shape that the crown should take under the gums. And I'll do that on the lingual side. Do the same thing, and here's where the clinical crown emerges. So right now, we can see what the shape of this tooth under the gums is going to be. And we have an emergence profile. So if I want to put teeth in place here, I will take, let's see what tooth we're on. I think it's going to be 9. Okay. I'll take number 9 and click it. Now add it in, and here it is. Okay. Actually, let me do something here. Let me get rid of both of these for now. All right. Those were in there previously, so I'll add this. I'll put it in, and here we have a tooth out of the library. And you can see where the incisal edge of this tooth is. So I'll take this, I'll try to follow the facial contour and angulate this tooth to match that. So now we can see that we have a pretty good angulation and placement of the tooth itself. And we can also see down in the 3D, let's get rid of that, let's get rid of the bone. We can see in the 3D that we have a tooth in a good position. It's a little bit short. I'm going to raise it. Okay, we have the ability to manipulate these teeth in shape and size. If I hover over this tooth, you'll see a purple ball and a blue ball, and basically what they do is make these teeth longer or shorter. But what I want to do with this is keep the incisal edge where it should be and try to keep the margin area of the crown right at the gum line where it should be. And that's what you see here. So if I were to hide that tooth, you would see that we have we had to take this tooth out off the model before we scanned it, so we could make a guide that had a site for a sleeve. But we also have a receptor site for the tooth itself, and we put that tooth into the site. Now we go occlusally with that, and we can manipulate the tooth position to a point where it's a very good position. Actually, that's number 10. I'm going to narrow it out just a little bit. Okay. So this particular emergence profile, you can see, is going to be for a cement or a cement retained crown. And how do I know that? I'll put an abutment on this, and I usually like to do what we call the custom abutment, and I'll make it 20 millimeters long by 2. That's my preference. That's a personal preference. And all of a sudden we have a trajectory of the implant. Now, to find out what angulation that implant is, or the abutment is going to be in the final restoration, if you look on the right side, I'm going right here in this right column, it says abutment custom, and I'm going to just keep changing this angle until we get to a point where the abutment is in the correct position. And so, okay, it looks off. And how do you fix that? We have this little wheel here that we can turn. That's the tooth. We want to use the implant itself, or this wheel, and we can turn this to line up properly. And the way I know that it's lining up is you'll see this red line or an arc. If you look at it this way, you'll see it. That pretty much determines the way that the abutment is going to move facially or lingually. So we have a 22-degree emergence on that one, and I don't like to go past 20 on angulated abutment, so I have the ability now, since I've corrected the position of it, to keep that right at the incisal edge where it should be. And now we have a 15-degree abutment, and 15 degree is a pretty common angle. Most companies sell a 15-degree abutment, and we have a good angle now to make a cement retained crown with a custom angulated abutment. But that's how I would arrive at that. If we were going to do screw retained, well, let me put the other tooth in too. Now, if you want to see how I can determine a tooth with roots, I'll pick the same tooth and I'll place it right over top, and here you can see the root on the tooth. And these teeth are made the same. The only difference is, size-wise, is that there's no root on one tooth. Whoops. So let's do this. We can do that. And I'll move this to where this tooth. Wait a minute, what did I choose? I chose the wrong one. Let me get rid of this one here. I want to choose a lateral. I want to choose number 10. There we go. That's why that had such a big root. There we go. Okay. So we'll move that into position. And we can follow the angulation of the tooth. Now we have to change the trajectory of the incisal edge. And we'll do that here. We also need to make this wider. We can do that. Okay, so now you see that these teeth are starting to line up with one another. Now, one thing we can't control on these teeth is the angle of the root. And what we're really interested in here is getting the coronal, the clinical crown lined up, superimposed over the crown that doesn't have a root on it. So if you look in the top right picture, you'll see that this tooth is aligned in between the adjacent tooth nicely, and we can determine emergence profiles right here. So here's the top of the implant, and I'll get rid of these. I'm gonna draw another line on that. Okay. So again, what we want to look for is the emergence profile of the tooth. Now I'm going to take that tooth and make it translucent. So now you can see that our emergence profile lines up. One thing, Michael, that is something that I don't know that you can change, is that once we put these teeth in place over the implants, it kind of hides the implants and you can't see all of it, even though they're transparent. I don't know if that's something that can be corrected or not.
I think you can make it more transparent, you know?
Yeah, but what happens, see what happens, it still doesn't show the entire implant. So for me to see the entire implant, I have to turn the tooth off, and I moved this implant a little bit in doing all that, but there it is. So I'll turn the tooth back on and turn the translucency back. Okay, so you can see our emergence profile now. It comes out of the gums right here with a nice emergence. Now we'll go to the screw retain design, and I'll show you how that changes. Okay, so this is cement retained. You can see that it's got enough bone around it. So screw retained, the first thing I'll have to do is go to implant list, change that abutment angle to 0, and now you can see that we the screw access hole will come out of the facial of the tooth, and we have to design a crown for screw retained. Now you see very graphically now how all the dynamics of this tooth change, meaning that the emergence profile is now not the same. So I'm going to change this. I'll put another one in place, another marker, and I'll go from the gum line at the margin and come back here. Okay, and I'll do the same for this side. And add another marker, and here's the gum line here, and here's the implant. So now you can see very graphically how much more of an emergent size we have, meaning that this crown is going to be very difficult to seat, maybe, depending on the patient and the tissue texture. When we make this crown in the lab, we'll have to contour this out and up. So, quite often these things need a little help in getting seated. So it's much more difficult for the technician to design this subgingivally as it is to design the previous cement retained one, because the cement retained design was more of a natural emergence. However, screw retained is desired, so that's why it's going to be very advantageous to create a sulcus before you make the final restoration. So what quite often happens with the screw retained crowns is that in the lab we can create a sulcus. We can take our soft tissue model and take a diamond and create a sulcus and build this crown to this shape, but if it's the final crown, you may have a seating problem. It may have be very difficult to get seated, and the doctor may have to curettage or release the gums a little bit with a small incision, and it can get very difficult to seat, and quite often they'll go right in. So you never know from patient to patient. But I think you've seen graphically here the illustration between cement retained and screw retained and the ramifications they have with the emergence profile. Okay, so from there I'll continue on here. I'm going to close this. Does anybody have any questions come in about this yet, Mike?
Yeah, there are some questions that came in that you've already answered during the presentation. Okay. There's a question that came in now just asking about importing a model or an intraoral scan.
We are going to address all of that in the 4th program, and that'll be in January. We're going to have that particular scenario or that particular presentation is going to have a lot of state-of-the-art importing of models, placing. We're going to show how we can place an analog in a model that we make at the lab that's indexed to the timing of the implant from just a CT scan and digitally scanned arches that we import into software, meaning that there's no models involved at all. Everything's digital. So we're going to show in the last lecture a lot of what we can do with scans from all the various scanning machines that allow you to send STLs of scanned arches to us. So I don't have that in this one, but in January, the last one, I think it's like the 2nd or 3rd week in January, that's what we're going to present. And it'll be a wealth of information about that. Okay.
And there's another question asking, Dr. Verbin's asking about screw retained versus custom abutments.
Screw retained versus custom abutments. Well, I think that custom abutments, I don't know that there's a comparison for it. Custom abutments are obviously cementable type crowns. So the best thing I can say about is screw retained. There's 2 reasons for screw retained. The 2 main reasons. One is simply for retrievability. If you have a patient that you feel you may have to take that crown out periodically or whatever, and that's one reason for it. The second reason is the cement issue. cement not being cleaned out of the sulcus of the gums. But the comparison of the two, they're just two different dynamics, actually. If you want to do, and it also depends on the bone. There are times when, because of bone angulation, that screw retain's impossible because the bone will not allow us to design the implant placement that's compatible with where the tooth needs to go in the arch. So I don't know if Dr. Verbin's asking me my opinion on which is better. I don't think there's a better, one's better than another. I think they're just two different restorations that have two different dynamics to them that you can end up with the same result. Okay.
He followed up by asking, all custom abutments can be made to allow easy cement removal. Why be concerned with cement removal?
Well, I'm not. I tried to illustrate or tried to demonstrate what the literature is saying right now as far as what they have determined to be one of the main causes of implant failure. So there's a concern out there about it, and custom abutments can be designed to have the margins a half a millimeter subgingival. So there should be no reason for a cement problem. You can take these abutments sometimes, and depending upon where the screw hole is, and you can cement the crown to the abutment before you put it in, and just leave a small hole for the screw access. Now, if it's an angulated type of an abutment, you can't do that, but at the same time, you can create a margin that doesn't have a deep sulcus, and that's all very maintainable and controllable when you cement your crown on. There are techniques where you take the abutment and put some cement in it, and you have to have a long working time cement, and take the abutment and put the crown on top of it, let most of the cement ooze out and clean it up, take the crown off, put the abutment in place, and then cement it on, and there's not a lot of cement left to express out into the sulcus. So I don't think one is better than another. I think that because of the way we're able to make crowns and abutments now, that we can control a lot of that, and not have such a worry about that issue.
Okay, Dr. Poirier is asking, why not ask the lab to cement the crown on the abutment and then screw it to the implant?
We can do that. Yeah, that's possible in certain situations. Yeah, we can do that. If we cement a crown onto an abutment, there has to be a way to get to the access hole. So, if, for instance, the trajectory of the implant places the access hole through the facial of the crown, then obviously I don't think we want to try to do a cementable crown or a cementable crown on that. Now, there's ways, something, it's kind of exotic, but you can put lingual screw access holes in these crowns, and you could deal with it that way. So you have a cement kind of a crown with a screw that holds it on. But it all depends on where the trajectory of the implant goes and where the screw access hole goes as to whether we can cement a crown on a tooth before it's put in the mouth.
Okay, I think that's it for now. We could go on.
Okay. All right, so let's go back to the program here and do that. So now, this happens in the posterior more often than it happens in the anterior. And I see this a lot in the posterior because we get a lot of ridge atrophy on the buccal side of the arch. And we have a lot of situations where the teeth overhang the arch on the buccal, and you can create concavities at the gum line. So these pictures here demonstrate that pretty graphically, where the crown itself is in a position where it needs to be in the arch, but you can see that there's no bone there to help support that. But at the same time, this is where the crown would come out of the gums if there were still bone there, and I suspect at one point there was bone here, but it's resorbed. So if this implant is placed in this position in the bone where you don't have to do a graft, we're going to have an emergence profile if we want to keep the facial surfaces of the tooth lined up with the adjacent teeth and create a hygienic situation. We're going to have an emergence profile that's pretty extreme and very difficult to deal with in the gums. So, and you can see what it looks like down here. It looks the same, and it's a big overhang. So if we were to change the position of the implant a little bit and allow for some facial grafting here, you can see how this emergence profile changes, and we can create a situation that is much easier to deal with periodontally. It's much easier to deal with just from the physics of screwing the implant in the mouth, and you might not have as much tissue management to do to get the crown placed in the mouth. So grafting planning for grafts on these things is becoming more and more looked at least with the people I work with, as a way to create good aesthetics where it's necessary and good hygiene, which we want everywhere, especially in the posterior where the cleansability is harder to get to. So this case I'm going to show, it's going to be replacing 30, and you'll see there's a graft in place here already. There's been a socket preservation. And you might ask the question, well, why ruin a good socket preservation? Well, I'm going to show you what I did here and how all of this really allows us to make a better crown, even though we might have to remove some of that socket preservation. So here's the tooth in a position in the graft where no grafting has to be done whatsoever. And it's a nice graft. But if you look on the picture on the right, you also see that if we want to have this crown emerge out of the gums so that there's no concavity here, as there might be if we use this straight position, there would be no concavity in this area. We have to change the design of that. So this is a graphic example of what happens. This is placing an implant in the bone with bone surrounding the implant everywhere. But if you want to have if you don't want to have an emergence profile that comes straight off the crown, and you want the crown itself to emerge out of the gums in a position that allows it to align itself with the adjacent teeth, this is going to be tough. You're going to push tissue out of the way. It's going to be a very difficult situation periodontally to deal with and to get a crown seated. As opposed now, and if you don't make this emergence, if you carve this tooth so that it has a more gentle emergence, we're going to come up with a porcelain like this that you see where this arrow is, and there's going to be a big concavity here around this patient's tooth, which can collect food, and the patient has to be very diligent about cleaning. Now, maybe it matters, maybe it doesn't. This demonstration here is just to show how we can improve the emergence profiles of teeth, not to say whether one is better than the other, but I'm sure that if you've done enough implants, you've looked at cases where you have teeth in a line and the gum line on all the teeth are even, and all of a sudden you have an implant in and you have a kind of a high ridge and you have a real short tooth. And if it's in an aesthetic zone, the patients, quite often they don't like that, and then you have a real problem on your hands because the implant's in and there's not much you can do but ridge lap, make a ridge lap crown that's very difficult to deal with hygienically. So as opposed to changing the position that you see here, we've moved this implant out to the point where you're going to have thin facial bone. You may have to take some of this bone down above the implant. You'll have a shorter implant, but at the same time you can see what the emergence profile is going to be. It's going to be a lot kinder. And so on the right side of the screen here, this emergence profile shows that we can have this crown shaped to come down and emerge out of the tissue in a natural form. So it's something that can be done. It's a lot of work. It probably gets a little more expensive, yet it could, on some cases, make the difference between success and failure. and whether that be through implant failure or whether it be through the failure of the patient not wanting to wear the crown or not liking it, and just causing issues that way. So let's go back to here. I have this on the screen. This will probably be the last demonstration that I'll show here. We're getting closer to 8 o'clock. Okay, so here's the same case, and these roots obviously they're way too close to the nerve on this tooth. I can't control how long those things are. To some degree I can, but if I want this crown to demonstrate what I want it to, I can't necessarily do that. But here you can see what I'm talking about. This is a natural emergence out of the gums, and if you look at this picture or this 3D of this case, it pretty much shows what I'm talking about. You can see that down the buccal corridor of this case, the tooth is aligned with the facial surfaces of the adjacent teeth. And at the gum line, there is no concavity that you have to deal with. At the gum line, this tooth emerges out of the gums in the correct position. Even though there's somewhat of a defect right there, it still emerges out of the gums in the correct position. It's very much more hygienic, aesthetic, and probably long-term better for the patient. So here are the teeth. Take that out, and you can see right now that here's the emergence position here, and I'll draw that. Let's see. Add marker. Okay. These are just some ways you can test how you want to approach a surgery. So when I put this tooth back in position, and you can see now that this isn't such a bad emergence profile. It has somewhat of a gentle curve to it. I'll put this tooth back in, and we will emerge where we want to. We will be able to create a decent emergence profile and have a tooth that fits into the arch and looks natural. So these are questions you have to decide patient to patient, whether you want to go through that, do some extra grafting to create something that should last longer in the patient's mouth. Now I know that grafting isn't 100% predictable, but I think at this point that these grafts that we're showing here are pretty routine and can be predictable as far as building the buccal, the facial of the bone out around the tooth. Okay, so this is just, I think, a very important part of this planning. We couldn't plan like this at all before we had this software, but now we have the ability to see how we can change the dynamics of this. Now I'll give you another graphic example here. I'll move the implant up to where we might have it as you saw in those pictures that I showed you, still pictures, and I'll put the tooth in. And what this is going to do is going to change the dynamics of this case. You would have probably been able to do this case screw retained if you wanted to. Now, because of the fact that we've changed this angle to get this implant in, we probably can get a longer implant in. Okay, I'm sure we can, which is good. But if we put this tooth back into position, now you see that we can no longer do a screw retained crown. So let's go back to implant lists, and we have to now change that to a custom abutment of about 14 or 15 degrees, which is okay if you don't mind that. But let's take this tooth out for a second, and we have to now change the emergence profile. So where we once had a gentle emergence profile, now we have a pretty severe one on the buccal right here. And basically what's going to happen, what would probably happen on this case is we wouldn't even do it that way because of that, and we would end up making some kind of an emergence that would be like this right here, and we put the tooth back in place, and you can see how much of this part of the tooth won't be there after the molar's carved, and you'll have a concavity on the facial of the tooth. I mean, I hope everybody can see that pretty clearly, but I'll show it like that. This is the part of the tooth that we would not include on the carving of the tooth itself, so that the implant crown would emerge out of the gums. The only way we could solve this problem is to do a ridge lap right here to make this either satisfy the patient or have it align itself with the adjacent teeth. Now, like I said earlier, that may not be something that you'll do on every case. In some instances, it's okay to have that concavity, but that's a clinical decision you'll make, at the time. So today was to show you how, basically my main message here was to show how we can plan for grafting cases, how we can plan for cement retained cases versus screw retained. And I think that it's a pretty, it's pretty valid information. So
some questions that came in.
Okay.
What do you think about the relationship between the implant and the buccal cortex? Can the implant be compromised?
Meaning if it's too close to the buccal cortex?
Yes, I believe that's what he meant.
Okay. I think that if you really look at what's being done in dentistry right now, grafting is done all the time. I think that what you're asking is, are we going to get bone that dies back around the implant? And I think if you didn't graft this, that you would. And again, I think that there's a lot of factors that play into doing this on a given case. I think you have to clinically decide if that patient is going to be a candidate for a graft. So if you plan to do a graft, then I think you have to make sure that it's done in a fashion that you can guarantee, whether it's with titanium mesh sometimes or however you want to do it, or with a membrane. I think that you can, in fact, ruin the cortex at this area, right where the bone is thin, if you don't graft properly. So if that's a concern, then I wouldn't graft that patient. But I know, a lot of the people that I work with around the country and certain parts of the world, they do this, and it becomes successful. I also know that I've had cases where we have these crowns emerging out of the tissue that are a lot shorter than the adjacent teeth, and the patients don't like it and they want something done about it. So it's a good question. I think that you have to take a lot of care with the graft you do and select your patients properly for it, but I think it can work.
Okay. Dr. Verbin's asking for clarification if the implant is deep enough, the proper emergence profile can be made with a custom abutment, correct?
That's correct. As long as we have the ability to countersink properly without, on lowers obviously, without violating the nerve or going into the sinus or the floor of the nose, that can be done. Yes, absolutely. You can create your emergence profile by countersinking and maybe taking some bone down so that we have enough running room to create an emergence. That's absolutely right.
Okay, and he's also commenting from the surgeon's perspective, bone needs to be removed prior to placement. Implants many times need to be shorter.
Mm-hmm. They do. And this is a graphic example of why they need to be shorter here, just to create a positive site for a tooth to be replaced. I think that's what he's referring to. If you're going to remove bone, if you do it beforehand, you can plan how much bone to remove in the software and go in and take that out and come back and put the implant in. Sure, I mean, I have some doctors that actually put the implant in and remove the bone around it. So there's there's techniques to do it either way.
Okay, there's a question that came in asking who's marking the nerve canal? Can we incorporate radiologist reports into the software?
I'm sorry, I didn't catch the last part of that.
If radiology reports can be incorporated into the software.
Well, radiology reports are available. I don't think you can. If you want to, we have a CT order form, we call it, and on that form, it's really a prescription that we use for these kinds of cases, and we have a section in there that says, would you like a radiological reading of this scan? And we can do that. It's not incorporated into the software. We send the plan to the company we use. They look at it and they send back a radiology report, and they'll tell us if the nerve's in the right place. We design the nerve in the software, and typically when I get online with a doctor, we'll go over where the nerve is, and I'll show him how I did it, and he'll either approve it or ask me to move it here or there. The biggest question a lot of times is the anterior loop. Where does that go? But there's pretty much a 5 millimeter parameter for that if we stay 5 millimeters anterior to it, we're usually okay. But a radiographic reading is available. It's not part of the software. It has to be looked at in the software by an oral radiologist.
Okay, there's a question asking if this tracing of the soft tissue in the image is taken from the model scan.
It is. What we do is whether we use a scanning appliance or not, we can get models into this software now either way, and we have to superimpose the model scan over the patient scan into 3D, and this is simply an outline of that model scan in the edentulous area where the implant's going to go. That's exactly what that is. So we can tell where the tissue is, where the tooth's going to emerge out of the tissue, and how much running room we're going to have for that. That's correct.
Okay, before we wrap up, I'd like to emphasize that everybody should put their information into the webinar attendance form in order to receive the CE credit. Okay, the webinar attendance form, the links are posted below the video screen, and it was also sent earlier today in the viewing links email. So please make sure to complete the information if you want to receive your CE credit. It should arrive within a week via email. Joe, do you want to bring up your contact information or Ro's website?
Yes, let me do that right now.
If there are further questions, then Joe at ROE Dental could be contacted. You can also contact Blue Sky Bio by email, plan@blueskybio.com, or our phone numbers are posted on the Blue Sky Bio website.
Okay, here is our contact information here. My name's Joe Ambrose. Here's our phone numbers, and don't mind my 100,000 icons here. Everybody thinks I'm crazy, but this is our main line here. Our fax number is here. So my extension is 303. As you can see over here, right here, 303. And if any of you have screen captures, you can capture that and have our information.
The next webinar presentation that's going to be given by Joe is scheduled for January 12th on the topic of turning removable cases into fixed cases. I'm also giving a presentation this coming Wednesday for those who like to get more involved in their own surgical guide fabrication. There's a webinar on surgical guide fabrication from the Blue Sky Plan software. The details are on the Blue Sky Bio website. Joe, you got 2 thumbs up from Dr. Verbin.
Oh,
And
good. Thank you.
I'd also like to thank you for tonight's webinar presentation and for taking the time to do that.
Well, you're welcome, and I appreciate everybody's attendance and interest. And if I can ever be of service to anybody, simply call me, and I'll be happy to work with you. So thank you very much, everybody.
Okay, and I'd like to thank everybody for attending. Have a very good evening.
Thank you. Bye.
Bye-bye.